In this section, we'll talk about the secondary prevention of ischemic stroke. This would apply to any patient who's had a stroke, and now you want to identify their risk factors and possible treatment options to prevent recurrence. So, our objectives will be to identify risk factors for the stroke. Think about which of those risk factors are modifiable targets that we could look at and review the drug therapy for prevention. So, to start off with, now that you had somebody who's had a stroke, again, that was due to some sort of clot, it makes sense that something like an antiplatelet agent that inhibits platelet activation and aggregation would be useful for preventing further strokes. And as a review, you know there are the thienopyridines, aspirin, and dipyridamole. These all work through different mechanisms with the end result of, again, inhibiting platelet activation and aggregation. Because of this, an antiplatelet agent is recommended in all patients with a non-cardioembolic ischemic stroke. That means an indication other than atrial fibrillation. Atrial fibrillation would be a cardioembolic cause. So just as a quick review of aspirin, the reason why this tends to be our first-line agent is it has the most data. It's been supported in multiple studies as far as decreasing the risk of stroke by about 15 to 25% and decreases the early recurrence of stroke overall. As far as how it works, just as a quick review, but it inhibits the COX enzyme. This then inhibits thromboxane A2, which downstream will inhibit platelet aggregation, and it is an irreversible inhibitor for the life of the platelets. The dose recommended for this indication is pretty low. It's the 50 to 325 milligrams per day. I would say typically it's dosed at 81 to 325 milligrams per day. If patients did not get TPA, it can be started within 48 hours of the onset of their stroke symptoms. If they did get TPA, again, remember you want to wait at least 24 hours before starting aspirin therapy. Adverse effects, as you remember, are mostly GI upset, potentially ulcers, and diarrhea. Another antiplatelet agent is dipyridamole. This one has a couple different mechanisms, but by decreasing adenosine uptake and decreased cyclic AMP phosphodiesterase, which then increases your levels of cyclic AMP, that inhibits platelet aggregation. Agrinox is actually available commercially as a combination capsule, which you could see at the bottom right of the screen. In this case, the dipyridamole is an extended release formulation. Those are the little yellow spheres that you see within the capsule. And then the white circle in the middle is really just an aspirin 25 milligram tablet. So if you're talking to your patients, you want to definitely tell them not to open or crush this capsule because it messes with the release of the drug. It's dosed at 1 capsule twice a day, which is again 25 milligrams of aspirin and 200 milligrams of the dipyridamole twice a day. Evidence for use of dipyridamole comes from the ESPS2 trial, which was the European Stroke Prevention Study. And what they did was they compared placebo versus aspirin alone versus dipyridamole alone versus the combination. And they found that the combination was definitely more efficacious for decreasing stroke risk compared to placebo, decreased risk by 37%, but that the combination was also superior for decreasing stroke risk versus aspirin alone. So you can see there it decreased risk by 23%. But if you look at the absolute risk reduction for the combination versus aspirin alone, it's only an absolute risk reduction of 1.5%. So it's not a huge decrease in events. As far as adverse effects go, the most common thing that patients report is headache. This is typically self-limiting and goes away in a few days. If you compare bleeding risk, it does seem to cause less bleeding than aspirin. Another class of antiplatelets is the thienopyridines. These are agents like clopidogrel or Plavix and ticlopidine. These work by inhibiting the last step in platelet aggregation induced by ADP. Evidence for this class comes from the Capri trial, which looked at clopidogrel versus aspirin. And in this case, clopidogrel decreased the combined endpoint of stroke, MI, or vascular death by 8.7%. They also looked at specifically patients who had a stroke, and although there was a trend for benefit, they didn't find a significant difference. Again, kind of talking like we were about dipyridamol, if you look at the absolute risk reduction in the primary endpoint of stroke, MI, or vascular death, it's only an absolute risk reduction of 0.53%. So, again, not a huge difference as far as decreasing events. Compared to aspirin, clopidogrel was associated with fewer GI bleeds. Of the two agents in this class, I would say ticlopidine is hardly ever used because of the adverse effects. A lot of diarrhea causes most patients to discontinue, and then you also have some of the neutropenia and blood dyscrasias. So for that reason, clopidogrel would be the agent of choice in this class. It's once a day and is much better tolerated and may have less GI bleeding than aspirin. So in summary, for secondary prevention of the antiplatelet agents, aspirin again is typically our first line agent. It has the most evidence and experience, and advantages are what we discussed before. It's once a day, it's cheap, anybody can get it. Disadvantages are the typical things with aspirin as far as GI upset and potentially a risk of bleeding. When do you use dipyridamol? I would consider this if you have somebody who's had a recurrent stroke who is already on aspirin. Based on the ESPS trial, again, it doesn't cause a humongous decrease in absolute risk reduction, but it was slightly lower than aspirin alone. So advantages may be, again, a slightly better rate of preventing stroke recurrence than aspirin, also has a long history of being used. And I would say the major disadvantage is that it's twice a day dosing and the headache, but again, patients often develop tolerance to that. When do you use Plavix or clopidogrel? That would be for patients who are aspirin intolerant, maybe because of allergies. Remember, they wouldn't be able to use the dipyridamol or Agrinox combination because it actually has aspirin included in the Agrinox. Another patient population would be if they had a recurrent stroke on aspirin. Clopidogrel is nice because it's once a day, may have less GI bleeding than aspirin, but again, the absolute risk reduction was not very large compared to aspirin alone. The stroke guidelines in general say that any agent can be considered for initial therapy, but I would say in practice, again, aspirin is typically our first line. So in thinking that ischemic stroke was due to clots, people also considered, would anticoagulants like warfarin be effective? And in fact, this has been studied in several different trials, but what they found was it didn't really help as far as reducing the frequency of stroke recurrence, and patients just bled more. So it's not recommended for non-embolic ischemic stroke. However, for patients with warfarin or a cardioembolic source of ischemic stroke, warfarin is definitely more effective than placebo, but also more effective than aspirin or the combination of clopidogrel plus aspirin. And although we talk a lot about the difficulties of keeping patients on a stable dose of warfarin, overall, if you can keep them in a goal INR of 2 to 3, it's been shown to be relatively safe. Major bleeding rates you can see there of 1.3% are fairly similar to those seen on patients on aspirin or placebo. So how does the stroke guidelines view your treatment options for patients with AFib? Based on the available studies on the individual agents, right now the strongest evidence supports warfarin and apixaban or Eliquis. Dabigatran has been shown to be non-inferior. They also say rivaroxaban is a reasonable option. So essentially the guidelines just say select the agent based on the risk factors, cost, tolerability, patient preference, drug interactions, etc. I'll refer you to the details of your lecture on atrial fibrillation for the general agents and their properties, but I just included this chart as a reference. Generally, once you've determined that a patient does qualify for an oral anticoagulant like warfarin or the newer agents, generally this is started within 2 weeks of the stroke. It is suggested that you may wait longer than that if patients are at high risk for having a hemorrhagic conversion, such as a previous history or uncontrolled blood pressure. So moving on to looking at risk factors for ischemic stroke, there's quite a lot of them, but you can kind of separate them into different categories. So the first are non-modifiable. These are just characteristics of the patient that you can't really do anything about other than to note that having them does increase the risk. So age greater than 55 is a strong risk factor, and you see that the risk of stroke actually doubles with each decade above the age of 55. As far as race goes, African Americans are at the highest risk, followed by Hispanic patients. Male gender is also an increased risk factor versus being female. Potentially modifiable things, but that are more difficult to do, are listed there, but things like metabolic syndrome, alcohol or drug abuse, patients who may be at more risk for clots because of hypercoagulability disorders or oral contraceptives, patients with infection or acute inflammation. This can trigger the coagulation cascade, and so that's what increases the risk for stroke. What we really focus on for secondary prophylaxis with ischemic stroke are the modifiable risk factors. These are things like hypertension, atrial fibrillation, diabetes, and dyslipidemia. These things are definitely modifiable in the ways that you studied in all your other therapeutics topics. We'll spend some time looking at them, but hypertension is probably the single most important risk factor for stroke. Atrial fibrillation is also a very treatable cause of stroke as well. So looking at first blood pressure control for secondary prevention, we saw that it was important for the acute management of patients, but what happens after they go home from the hospital? If you look at the studies, they've actually found that stroke is associated with elevations in either your systolic or diastolic pressure. And there's been multiple studies that have found that if you decrease your blood pressure from baseline, it actually decreases your risk of stroke by about 30 to 40%. Even just being on any hypertensive med is associated with a decreased rate of stroke recurrence. And again, this is regardless of your baseline blood pressure. Benefits can be seen with even just a reduction in blood pressure of 10 over 5 millimeters of mercury. And the lower you can get your blood pressure, the lower the stroke risk appears to be. So for secondary prevention, what is the recommended? So based on the JNC 8 guidelines, it's recommended to target a blood pressure less than 140 over 90. The stroke guidelines also suggest that you may consider keeping the goal blood pressure less than 140 over 90, even if the patient's age is greater than 60, although this is not a hard and fast recommendation at this point. Recommended treatments for all patients would include lifestyle modifications such as weight loss, diet, exercise, a limited amount of alcohol intake. As far as what medications have the best evidence, again, no class has been shown to have a specific advantage for secondary prophylaxis in stroke. The PROGRESS trial did show a significant decrease in stroke when patients were given a combination of diuretics alone or diuretics plus an ACE inhibitor. So based on this one trial, the stroke guidelines recommend considering starting hydrochlorothiazide as a first-line agent plus or minus an ACE inhibitor or potentially an ARB if ACE inhibitors are not tolerated. When should this be started? I would say the majority of patients who have a stroke typically already have hypertension at baseline. So if they're already on hypertensive medicines when they have a stroke, this can typically be started within several days after the stroke. If it's new therapy, it's recommended again within several days after the stroke. This gives the brain and the body some time for that initial hypertension to equilibrate back to the baseline before you start adding on additional hypertensive therapy. So moving on to another target is lipids or hyperlipidemia. So it's been well documented in the literature that stroke is associated with elevated lipids, particularly your LDL. One example is the heart protection study. This looked at the use of simvastatin 40 milligrams per day, and they found that whether or not you had coronary artery disease, using simvastatin decreased your overall stroke risk. And even if your LDL was low, in this case less than 116 milligrams per deciliter, you still had benefits as far as preventing stroke recurrence with a statin on board. Another study was the Sparsel study. This used a different agent, atorvastatin, versus placebo, and these were patients who did not have coronary heart disease. And they found that with atorvastatin, it did decrease ischemic stroke by 18%. Kind of like blood pressure, the more you decrease your LDL from baseline, the lower your stroke risk appears to be. So, based on this evidence, a statin is actually recommended in any patient who's had an ischemic stroke, regardless of their LDL. The evidence is less strong if the LDL is already less than 100, but again, because you tend to see a benefit for decreasing stroke risk, regardless of your baseline LDL, we tend to recommend a statin in everybody. So, all patients, just like blood pressure, should continue to do lifestyle and diet modifications, and again, be started on a statin typically during hospitalization. For this, I would just follow the new lipid guidelines, but if the age is less than or equal to 75 years, we would recommend a high intensity statin. That would be something like Lipitor 40 to 80 milligrams, rosuvastatin 20 to 40 milligrams per day. If they're greater than 75 years, that's when you would use a moderate intensity statin, such as lower doses of Lipitor or rosuvastatin, or consider simvastatin or pravastatin. Moving on to diabetes, diabetes has definitely been associated as a stroke risk factor. About a third of ischemic stroke patients have diabetes, and about 9% of recurrent strokes are in patients who are diabetic. Diabetes does increase the risk of stroke at all ages, but most in age less than 65. People have looked at, how intensive of glycemic control is helpful for preventing stroke. They found that being more aggressive by keeping your A1C less than 6.5% did not give a benefit as far as reducing stroke. So what's recommended is really just keeping a general goal of A1C less than 7%. Target a blood pressure of less than 140/90 is recommended by JNC8. And a new recommendation from the stroke guidelines is actually in patients who've had a stroke to actually screen them to see if they have diabetes, again, because this is such a strong risk factor and it may have been previously undiagnosed. So other modifiable risk factors, things like smoking and alcohol, basically just don't do it anymore. Physical activity, you want to encourage your patients to do exercise with moderate activity 3 to 4 times a week. Those include things that basically make you break a sweat or raise your heart rate, like brisk walking, biking, etc. Metabolic syndrome, again, lifestyle modification, managing things like your lipids and your blood pressure. So in summary, for secondary prevention, you first want to look at things that are going to help prevent future clots. So that can be antiplatelet agents for patients who have had a non-cardioembolic stroke, or anticoagulants like warfarin or the newer agents for those that have had a cardioembolic stroke with a source such as atrial fibrillation. For modifiable risk factors like hypertension, again, the goal blood pressure that's recommended is less than 140/90. If patients require therapy, typically a diuretic such as hydrochlorothiazide is suggested as first line, with potentially adding an ACE inhibitor, or you may resume whatever the patient was on previously. Statins, again, are recommended for any patient with an ischemic stroke, selecting a high or moderate intensity statin based on their age as per the lipid guidelines. And for diabetes, hemoglobin A1C goal of less than 7%. Again, I picked out the main risk factors that are most common in patients, but you should reassess any patients for modifiable risk factors that they may have.